think everybody on the call, at least the faces I can see, know who our presenter is today, Will Hall. Will is really kind of a Carolina guy. He got a degree as an undergraduate here. He got his MSW degree from the School of Social Work, his PhD from the School of Social Work. He's a graduate and alum of our postdoctoral training program at UNC and Duke. And he's now an assistant professor at UNC in the School of Social Work. So can't, once a guy gets in town here, he can't really get away. And that's for our advantage, the university's advantage here. Will did his PhD in 2015. He was with us as a postdoc for a couple of years following that. And just talking with him, he's now 4 years into his position at the School of Social Work. And he's going to be talking to us this afternoon about some of his research related to the LGBTQ community, which is a major area of interest to Will. He has studied issues related to that community from a number of different directions of policy, clinical interventions, practice guidelines for how to approach and deal with some of the special needs and interests of that population. So looking forward to hearing about his ongoing work, which I think is related to a feasibility study that you were doing, Will. Yeah. So hopefully this will be something that will launch into something fuller, and be interested to hear the details of that. So with that, why don't I turn this on to record, and Will, the floor is yours.
Yeah, thanks, Joe. It's so nice to see so many old friendly faces from the postdoc. So let me pull up my PowerPoint. Okay. Yeah, so as Joe said, my work is focused on LGBTQ mental health disparities and addressing those in different ways. And I'll be speaking about a feasibility study I recently completed that was funded by a NC Tracks 2K pilot grant that I think I applied for at the end of my postdoc, and then completed it just after that while I was on the faculty. And I'd like to acknowledge Mimi Chapman, who was a co-investigator on the project, and Benjamin Ruiz-Rosado, who was my research assistant, who at the time he was a student, but now he's graduated and moved on to bigger things. So I wanted to start off by talking about some of the mental health disparities facing LGBTQ youth. These are data from the CDC's Youth Risk Behavior Survey. I think this is the most recent data set that's available. And, they asked several questions about depression and suicidality in the past year. So among the youth who said they felt sad or hopeless almost every day for at least 2 weeks. So that's kind of their single item question to assess a depressive episode. You can see compared to heterosexual youth, LGB youth were more than twice as likely to report feeling depressed. 66% is very high proportion. About twice as likely to say they seriously considered suicide. And then LGBT youth more than twice as likely said they made a plan for suicide in the last year. And then almost 4 times as likely to say they attempted suicide in the past year. And they also collected data from youth who said they were questioning their sexual orientation. As you can see, for the questioning youth, the rates are higher than the heterosexual youth, but not quite as high as the lesbian, gay, bisexual youth. So there's something that's sort of additionally stigmatizing for youth who identify as LGB or another sexual minority identity. These are data also from the Youth Risk Behavior Survey. A few years ago, they started asking questions about gender identity. Not every state asks about gender identity, so there's actually no nationally representative data on transgender people, but this is kind of the closest we could get for transgender youth. So you can see, compared to cisgender youth, trans youth were almost twice as likely to report feeling depressed, 3 times more likely to consider suicide, make a plan for suicide. The disparities are really pronounced for attempting suicide in the past year, almost 5 times more likely. So some really startling numbers. If you're, a mental health professional, or someone who studies or cares about mental health, and you may be wondering, why do we have these disparities? Why are they so pronounced in terms of depression and suicidality? And so when we look at the social landscape, so these states in red are states that do not have a law that explicitly protects or specifically prohibits bullying in schools based on sexual orientation and gender identity. So there's no federal law. Every state has passed a law, but most states, there's no explicit protection for bullying based on sexual orientation and gender identity. So these states in red, they don't have laws prohibiting discrimination at school. In most parts of the country, mental health professionals can practice conversion therapy or reparative therapy with minors. So that's I don't even like to call it therapy, but that's an approach where a mental health professional will try and change a young person's sexual orientation. So they help convert them from being gay or lesbian or bisexual to being heterosexual. In most of these approaches, there's a significant religious influence. So we don't have a federal law prohibiting employment discrimination based on sexual orientation and gender identity. Last year, the courts ruled that I think it's the Civil Rights Act of 1964, which does prohibit sex-based discrimination, does apply to sexual orientation and gender identity regarding employment, housing, and public accommodations. But that doesn't have the same legal weight as a federal law or even a state law. These states in red don't have state laws. There's not a federal law, although that may be changing. The Equality Act is a bill that's passed the House and gone to the Senate that would amend the Civil Rights Act of 1964 to include sexual orientation and gender identity as protected classes in terms of employment and housing and public accommodations. But for so long, this kind of gives you an idea of the patchwork of legal protection, or the absence of legal protection for different forms of discrimination for the LGBTQ community. And then in addition to the policy landscape, about 40% of LGBTQ people said they had been rejected by a family member after they came out as LGBTQ. There's high rates of verbal harassment and physical harassment reported by youth. Discrimination in schools often takes many forms. Youth saying they were disciplined for public displays of affection, being discouraged from doing LGBTQ topics for a class assignment or a class project. And then in, our churches and other faith communities, even though, same-sex marriage is legalized now, still most of the major religious organizations still oppose same-sex unions or prohibit their clergy from performing those ceremonies. And 30% of LGBTQ people said they were made to feel unwelcomed at a place of worship. And these are all national data. Some are from nationally representative studies. So there's oppression at all levels of our society that LGBTQ youth are growing up in and facing. And so that's what's primarily driving these mental health disparities. So the study I'm going to be talking about today, it's a feasibility study for an intervention I developed called Being Out with Strength. And it's a 8-session manualized small group CBT, an adapted CBT-based intervention to reduce depression among LGBTQ youth. And I started developing this intervention when I was a doctoral student. We had an intervention research class. So I started drafting it then, and over the years I worked on the manual at different points and then finally finished the manual. So the research questions for this study, is there a demand for this intervention? Is the intervention acceptable for the target population? What are potential implementation issues that should be addressed if the intervention is going to be successfully delivered? And so I chose to do a feasibility study as kind of a starting point in the research process with this intervention. And part of that is, where I was in my career. But a feasibility study is also a good starting place when you kind of have an intervention that's developed, but it hasn't yet been tested or evaluated. And it's good to do a feasibility study when there hasn't been many prior studies using a specific intervention approach. And this intervention, it's an adapted CBT intervention. So that, there's been plenty of studies on CBT, but very, very few studies with using CBT interventions with the LGBTQ community. And feasibility studies are also needed when there's kind of your target population has unique needs or issues that you might need to investigate before you do a full intervention trial. And so, the LGBTQ community is a vulnerable population. They face unique stressors. So that was kind of another reason that why I wanted to do a feasibility study. And depending on the findings of your feasibility study, that can be a kind of go, no-go test for an intervention moving to the next step of evaluation in terms of investigating preliminary efficacy. And your feasibility study findings can be used to inform your intervention trial. And if for people who aren't familiar, most of where I read about and learned about feasibility studies was this Bowen et al. Article, How We Design Feasibility Studies. It provides a really good overview of the rationale for feasibility studies, the different feasibility variables that you can investigate, and some of the methods for investigating those feasibility constructs. So I just want to recommend that article for people who want to learn more about a feasibility study. So for my feasibility study, I did a pretty simple descriptive cross-sectional mixed method study. It was guided by the Bowen et al. Article, which is feasibility studies specifically for behavioral health interventions, and kind of the key feasibility variables or concepts that I decided to investigate in my study. So one was demand. So is there a need for an intervention? Acceptability. So the extent that your intervention is suitable, interesting, attractive to the people who are going to be delivering your intervention, as well as the intended recipients of the intervention. Implementation, so the extent that the intervention can be successfully delivered as proposed. So these were kind of the three constructs or concepts, feasibility concepts that guided the project and the data collection. And so we actually recruited 2 samples. So one sample was LGBTQ youth, so the intended recipients of the intervention. And we, just did a convenience purposive sample of looking for LGBT youth in the Triangle region. And we posted about the study on some Facebook groups, specifically for LGBTQ college students. I also posted about the study in the personal ads of Craigslist, and then we put up some flyers at some coffee shops. And then the second sample we recruited were mental health service providers. So the people who would be delivering the intervention. We recruited them from the Triangle. I think it was either one or 2 of the LGBTQ centers here in the Triangle have online listings of affirming mental health professionals. So we just went to those listings and just started emailing different providers to see if they were interested in participating in our study. And so for the youth sample, we had 79 youth, ranged in age from 18 to 28. Most were in their early 20s. It's mostly white, so it wasn't quite as racially diverse as we wanted. About half cisgender female, not quite as many men, and then we also had some almost a third of transgender youth in the sample. And you can see they had identified in different ways, including saying they had multiple identities, which is I think more and more young people are identifying as say they have multiple identities. So they might identify as bisexual and queer, or pansexual and some other identity. And then for the mental health service providers, the sample was 9. Again, it was mostly white women, which is kind of typical for mental health service providers. Some identified as transgender, some were heterosexual, or about half were heterosexual, about half were LGB. Most of them were licensed professional counselors. We had a couple clinical social workers, an art therapist, and a clinical psychologist. And about, on average, 12 years experience among that group. So they'd been practicing a good while. And often, the LGBTQ community was one of their client groups that they focused on serving. So let me tell you a little bit about the intervention design. So it is based on cognitive behavioral therapy. And, you know, there's been several meta-analytic studies that show that, you know, CBT is highly effective in treating or reducing depression, whether it's delivered individually in psychotherapy or delivered in a group counseling or group therapy format. And, you know, I put in this little figure of the cognitive triangle with, you know, the thoughts, feelings, and behaviors that are interconnected. And, you know, CBT interventions target changing thoughts, changing core beliefs, and changing behaviors. And then I also decided for this intervention that I wanted it to be a group intervention as opposed to a more one-on-one counseling or psychotherapy type of intervention. And when I say group, I mean a small group, like about 8 people per group is what I intended. Group interventions are often helpful when there's a common problem focus. So in this case, depression. So everyone in the group would be struggling with depression to some degree. Group interventions are also beneficial when there's a common identity. And so in this case, it's LGBTQ youth. And then unlike one-on-one interventions, some things that I think are strengths of group interventions is that people in the group engage in mutual social support. And often the group becomes its own little community. And people in the group often become friends. And those friendships last outside the group. And then, you know, with depression, people often become socially isolated, right? They withdraw, they stop engaging in their typical activities. And so a group intervention is nice because it can challenge those feelings of isolation. And then also, you know, group interventions are more cost efficient than one-on-one interventions. And then this is a diagram of minority stress theory that was developed by Alon Meyer, who's now at UCLA. And it's kind of the dominant theory that's used to explain mental health disparities among LGBTQ people, with the primary idea being that there's these general life stressors that everyone experiences, but then the LGBTQ community experiences these additional minority-specific stressors. And he refers to these as prejudice events, which can be various prejudice-based kind of stressors, expectations of prejudice events, concealment of identity, and internalized depression. And then there, you know, there's also some moderators in the model: social support, minority identity characteristics. And so with my intervention, it's primarily targeting internalized depression, which is also called internalized stigma, internalized homophobia, internalized homonegativity. It's called different things. I often just call it internalized depression, where LGBTQ people internalize these negative societal messages about their identity. So, you know, growing up, they might be bombarded by different messages from family members, people at school, the media, maybe their church or place of worship, that being LGBTQ is a bad thing. It means you're abnormal. It means you're a sinner. It means you'll never be able to be happy or have children or have a family. So those kind of messages become internalized and held as kind of true beliefs by LGBTQ people. And so that's kind of a lot of research has shown a connection between internalized oppression and depression. And then my intervention also focuses on valence, and so that's it's basically we're trying to cultivate this positive identity among LGBTQ people. So having a positive valence in terms of their identity can help buffer against these minority-specific stressors, like when they're bullied or encounter social exclusion or discrimination or rejection. And then, as I said before, because the intervention's a group format, there's a social support aspect there that can influence or reduce depression. So this is, the theoretical model behind the intervention. As I said before, it's an eight session intervention, which starts off with, kind of introducing people to CBT, this core CBT ideas. There's group forming activities. There's reflective storytelling, mainly in the second session, where youth are kind of sharing their stories about their kind of LGBTQ identity development in terms of coming out to themselves, coming out to others. And then a lot of the subsequent sessions focus on youth kind of monitoring their thoughts. So looking for patterns in their automatic thoughts, so the thoughts that just kind of pop into their head, specifically about their LGBTQ identity. And then often, depending on the specific pattern in the thought, that kind of sheds some light on some of the core beliefs that youth have internalized related to internalized depression. So do they have an internalized belief that they're abnormal because of their sexual orientation, that they can never have a successful, happy life, that they're going to hell because of who they are, or they'll never be able to find a fulfilling relationship. So it's kind of individualized, where it's kind of the same techniques, but different core beliefs that youth have internalized can emerge from this process. And then in sessions, youth are taught thought-stopping strategies, creating alternative or more helpful thoughts to replace these sort of harmful internalized beliefs. There's affirmation activities. Youth look back on kind of where and how they've learned some of these messages that contributed to their internalized depression. It's an adapted CBT intervention, and primarily targeting internalized depression. So for the data collection from the LGBTQ youth, we did an online survey. To assess demand, we administered the short mood and feelings questionnaire that I think was developed at Duke. It's just, a short depressive symptom rating scale. For acceptability, we had youth read a 1-paragraph description of the intervention. And to make sure they read it, after they read it, they had to type in their own words, what the intervention was about. And so there were some people who started the survey and then dropped off at this point. But the 79 youth in the sample, they did the whole thing. So they didn't drop off when it was time to read the 1-paragraph description. And so after reading the description of the intervention, we asked about their likelihood of participating. For implementation, we asked, where they'd like to participate in the intervention, times of day, some other logistics. The mental health service providers, I sent them the intervention manual. I think I emailed it to them, and most of them printed it out. And then I met with them, and we did one-on-one interviews that I recorded, and they were transcribed. And for demand, I asked them about, kind of the frequency that they were seeing depression as a presenting problem among their LGBTQ youth clients. I asked them if they felt that there was a need for my intervention, if they thought it would be helpful. For acceptability, we asked if they thought youth would be interested in it, ages it would be appropriate for, identities it would be appropriate for, client symptom levels, number of sessions, durations. I also asked for their recommendations, and then implementation. Asked about a lot of logistical things related to the intervention, if it was going to be implemented as the next step. And so for the youth results regarding demand, so we took the scores from the short mood and feelings questionnaire, summed those up, used a cutoff score, and actually found that 46% of the youth in the sample had clinically significant depressive symptoms. And many more of them, had kind of subclinical levels of depression. And I think only 5% of the sample actually reported no symptoms of depression. And from the mental health provider side, in terms of demand, all of them indicated that depression was a frequent problem that they encountered with their LGBTQ youth clients. Most also noted that they felt that this was because society is often hostile and stigmatizing toward this group. All the providers indicated that there was a need for the intervention. One of the professionals said, we need targeted interventions for queer people, run by queer people, made by queer people, because we're disproportionately facing suicide. We need targeted, culturally humble interventions, and they're not happening. 3 providers said, they thought there was a need for a peer group for youth, so that they could feel connected, be in a safe space. All the providers thought that the intervention could have an impact in terms of reducing depressive symptoms by working through their thoughts and feelings using the CBT strategies. In terms of acceptability, so about 2/3 of you said they would be interested in participating in the intervention as part of a trial. 28% said maybe, and only 5% said they were not interested. And we did ask why, for the ones who said they weren't interested, why not? And some were, nervous about being in a group. Others said, their mental health problems weren't that significant where they would need intervention. Some said they were already seeing a therapist, and so this wouldn't be necessary. necessary. We did some chi-square analyses, so there were no differences in terms of interest in participating in the intervention by race, sex, sexual orientation, or gender identity, so that was good to see. And among those who said they were interested, 71% had clinically significant depressive symptoms. And then we also asked the youth if they thought they knew of a friend who would be interested, and 74% said yes, some of my friends would be interested in this too. In terms of providers and acceptability, the providers generally agreed that an appropriate age range would be 15 to 30 for this intervention. Most providers felt it would be appropriate for clients with mild or moderate depression, but not for severe depression. They might need a more intensive intervention. I did ask providers about, so one of the issues I often have in my work is, the LGBTQ community is this very heterogeneous community where there's, gay men, lesbians, bisexual people, non-binary people, transgender people, trans men, trans women, genderqueer people. So there's a lot of different identities. But one of the more common issues is, do we include transgender youth in our study or our intervention along with our cisgender LGBT youth? Because often the issues transgender youth are facing are different than cisgender LGBT youth. So 4 providers said, yes, have you can have this group would work. There's a mix of identities. But then other providers said, well, it would be great if you could have a separate group for transgender youth, but having a mixed diverse group would also work. Yeah, and this is a quote from one of the providers. They said, gender and sexuality are different things, even though some of the cultural messages are the same, and internalizing some of those negative messages are the same. Oh, where am I heading? Oh, I'm not sure where the heading is. Okay. We asked them about maybe it's on the next slide. Oh yeah, here it is. Some of the strengths of the intervention. A lot of them like the content, the group structure. Several of them felt that the manual was really easy to use. Some commented on the organization and the flow of topics. This helps raise awareness about where their stories come from. Developmentally, younger people have a tendency to internalize things and think things are their fault, but this really helps show the different layers of systemic oppression that are teaching kids these messages. And then another provider said, BOWS gives youth a tool to talk about different things in a safe way. So the intervention does include a lot of structured activities in terms of reflection and sharing and processing. So these are more acceptability results from providers. They felt 8 sessions was good. There were a couple providers who said that I might want to think about adding 1 or 2 sessions to teach some additional skills, or doing like a booster session. All of them felt that 90 minutes per intervention session was appropriate. They did have some recommendations for me to improve the intervention. Several of them wanted to make sure I had built in enough time in each session for youth to process their experiences and discuss the material. And for those of you who are familiar with CBT language, some of the jargon is, cognitive distortions or cognitive errors, or, we're going to engage in reprogramming your negative thoughts. And so some of the providers recommended I kind of modify some of the language just to be less jargony, but also to be, less clinical. A couple people recommended integrating more content on intersectionality. So talking about, the experience of being, in addition to LGBTQ, you might also be an LGBTQ person of color, or LGBTQ with who also has a disability. Talking about those issues more intently in the intervention. And then there were some minor recommendations for changing the format of things. Implementation, so the settings youth recommended for the intervention, most of them said, a college or university campus, and, most of the sample was college and university students. So that makes sense. LGBTQ center would also be a good place. Not as many said of, office of a mental health professional. And then a few mentioned a religious organization. In terms of times of day for the intervention to be conducted, most wanted it during the evening. Some said late afternoon would work. Less for other times in the afternoon. So providers, in terms of settings, said, almost all of them said that it could be delivered in a high school or a college or university counseling center, LGBTQ centers, outpatient offices. Couple people mentioned churches. The ideal group size, they said, would be 6 to 8. You need at least 4, definitely no more than 10. In terms of who would facilitate the groups, providers said 2 facilitators would be ideal, 1 would be enough. They should be a licensed mental health professional or someone in training to be a mental health professional. Some training in group work and CBT. And maybe ideally the facilitators would be members of the LGBTQ community, but allies can also be effective facilitators. Some barriers that might come up for youth participating in the intervention. So youth might not be out to their parents, or their parents might not be supportive of their child participating in a group like this. Stigma related to mental illness or stigma related to being LGBTQ. Confidentiality concerns come up with groups, and then logistical challenges like transportation issues. So to conclude, the findings suggest there's a need for this intervention. Depression is a frequent problem in this community. There's not, we have CBT interventions, but we don't have tested and evaluated CBT interventions for the LGBTQ community. So there's, preliminary acceptability for the intervention. It's not, this isn't the same as the youth actually participating in the intervention and then seeing if it's acceptable. So that would be good to know later on, but it seems like most youth were interested. And then providers had recommendations about who the intervention might be most appropriate for in terms of age range and symptom severity. And then we have a lot of useful findings about implementation issues that can really help craft a RCT study, which would be the next step to evaluating the efficacy and acceptability and implementation of the intervention in the next phase. So I really do want to, I plan on writing a grant to do an efficacy trial of this intervention. So that's kind of the next step for me with this research. And that's all I have.
Great. Nice presentation, Will. Great set of slides. I think you just done a very good job of sort of getting the ideas out there and so on. So I compliment you on that. Have you thought, I just have a general question, other folks may have one as well, in terms of it's the next stage of what you might do and so forth. From one point of view, the work you've done so far in the feasibility is kind of a conceptual feasibility. There was nothing in practice that was actually done. And the kinds of questions, that would come up in a research proposal would be, what evidence do you have that you actually can assemble the intervention that you describe? And how do you go about sampling the population? What do you do about the heterogeneity issue? Can you, in a research design, can you study all of the identities that you have alluded to, or does it mean to, concentrate in and so forth? And I would think that ultimately, once you had it together, a small randomized clinical trial to try to demonstrate the efficacy would be the thing to do. But it seems to me there are a number of things you need to do before you can write that proposal. I'm just wondering how you're thinking about that.
Yeah. So yeah, that is the next step I'm planning, is a kind of small RCT to evaluate the intervention. And when I set up to do this feasibility study, I think I was just hoping that the participants would just kind of confirm everything I was proposing. But in some ways, they brought up more issues, like, oh, maybe you should add a couple more sessions, which I, was resistant to, because, 8 sessions is
a lot.
Very feasible. Well, you think it's a lot?
I'll let Kathleen comment on that. Kathleen has a lot of experience at running small groups and the number of sessions and whatever. But
the first pilot we did of a parent intervention, we designed with 8 sessions, and I was just talking about this earlier this afternoon. We had to send project staff or taxis. This was before Uber, to get people and bring them. We had to feed them. They were parents with kids with multiple conditions, and so we had to have like highly trained childcare, and we had kids from like infants to their 20s, all with behavioral health care needs. And so it was really, really expensive to run. Per person, I think we figured out, this was a long time ago, it was like $1,000 a person just to fund running it. So then the second time we did 4 sessions, and that worked well for us. People came like 2.5 times on average out of the 4 sessions, but we got a positive effect. Later, we did a replication trial on this parent intervention. It was a time when politics were such that all of a sudden it became a lot harder to recruit parents, and there's a big reluctance to travel and be involved with us. So then we tried shortening it to 2 sessions, and out of desperation, we also tried allowing people to join by Zoom. So we had mixed in person and Zoom. And I think what I learned from that is 2 is not enough to have a group feeling bond, two meetings, and mixed sessions are awful because the people in the room feel like they're exposed to whatever's going on in other people's houses. Whereas it seems like I think that we are beginning to learn how to do healthcare and have professionals meetings on Zoom where we all kind of come to agreement about the kind of appropriate setting in the background so that we're not feeling exposed to some unknown stuff. But I was going to ask you about you made the point about challenges with confidentiality, and I feel like that's an ongoing challenge with a lot of group work. And I wondered
Mhm.
um, what your thoughts about improving that are,
Yeah,
safeguarding.
that's it's a really difficult issue. And you know, before I got my PhD, I used to run some groups with LGBTQ youth. Um, and I only had one instance where someone in the group broke confidentiality and was telling other people not in the group um, about someone's personal issues who another person who was in the group, and it became a dramatic situation, and then I had to sit down with them individually and then together, and part of me wondered if it was partly my fault if at the initial session, if I hadn't kind of seriously talked to them enough about the importance of confidentiality and how it's this responsibility that's shared in the group, and that no one wants their you know private business being shared without their permission, and so that instance really shook me and made me, from then on I was much more vigilant in the beginning about talking about the importance of that, and then when I was also running those groups, like we had to have it in this very private location, because some youth didn't want other people to see them going to the queer group meeting, because they weren't out yet to people, and so that was kind of difficult to navigate in terms of figuring out where we were going to have the sessions and make sure it was a private location and they could come in discreetly. So yeah, I don't know.
Do you think this could work as a total Zoom thing? I mean, Zoom to some extent would handle the privacy and confidentiality a little bit better because you wouldn't be going to a place, queer people only kind of,
Yeah.
stigma and so forth. But I don't know if the Zoom loses something in terms of the emotional support that you might get in a group.
Yeah, I think before COVID, I never thought about doing it as an online group, but now I think that would be a great modality, or a platform to do the intervention, and it'd be interesting to see have one group that's on Zoom and one group that's in person and collect some process data about those different experiences. And I've never done like teletherapy, but even in my teaching, like teaching on Zoom versus teaching in person, it's not the same. Sometimes I miss cues in body language, or people turn off their camera during class, and I'm like, where did they go? Are they upset, or are they getting a drink, or what's going on? But yeah, I think going forward, I think I would want to do it in different kind of
Modalities,
platforms, and kind of see if there's a difference or not.
If a young person had a private space, it seems like it would solve a lot of issues. But if a
Yeah.
young person didn't have a private space, if the
Mm,
computer's in the kitchen, or something, then it might be worse.
yeah. And another thing, that I just thought of, like we have so many more LGBTQ resources in like urban, big cities, urban areas, whereas the rural areas, they don't have like even, centers or places to meet. So I think doing it on Zoom could be able to reach more youth in rural areas who might be feeling even more isolated.
Does the Y support either groups or even research like this? It seems like it could be a suitable spot.
Yeah, I've thought about that too, and I think they would. I haven't talked to anyone from the Y, but I've thought of them. Yeah.
But because this is, you plan to have this facilitated by clinicians, does that mean that once you found evidence, it would just be a matter of, I don't know how this works, someone applies for it to be a billable service?
Yeah, I think they could. I mean, I was thinking of, having the intervention manual be available to anyone. And, anyone who's had training in CBT would be able to deliver the sessions. I don't think they need like specialized training from me to deliver it.
But
But I
does
know
that mean you think they should be a clinician, some kind of behavioral health?
I think so, or someone in training, like a social work intern in their second year, or a clinical psych PhD student could do this. Yeah, and I insurance does have billing codes for group therapy.
Mhm.
I think the reimbursements are quite as good as individual therapy, but
No,
And a
but you would
question,
prefer-
a question about that, Will. I'm just wondering, is there any kind of a, I don't know what, contradiction, in terms of doing this under the umbrella of therapy? Giving many of your introductory comments about stigmatizing the individuals, here the therapy sort of means there's something wrong with you that needs to be sort of dealt with and so on. So, I mean, there's advantages to doing it in a therapeutic setting. And I wonder if there are some negative imagery that is produced by that.
yeah, I think so. Yeah, I mean, even though I think we've made more progress, there's still mental health stigma, or the stigma of mental illness. Although, yeah, I swear, young people these days seems to be less for young people than maybe my generation or older generations in terms of, going to therapy or telling other, friends or family that they're in therapy. So I think there's a shift, but yeah, there's still some stigma.
Besides stigma, what about sort of feasibility of dissemination and uptake? We've gotten feedback that challenging the level of education of the facilitators that we tested, and asking, whether couldn't this be done by a peer, an advocate?
Yeah. But I think I mean, we only interviewed 9 mental health professionals, and they were, their mental health, they were all licensed. So they were like, oh yeah, you should be able to should be licensed to deliver this. But I wonder if I'd asked, more peer service providers if I would have gotten different answers.
Yeah.
Um,
We asked our partner clinic. They said, yeah, we do this through family therapy. And then, when a few years later they said, oh no, that's too hard, we're not going to bother doing that. And then this sort of other conversation started happening about more peer provided support and facilitation. It seems for ours, it's not nearly as clinical as yours, so it's something that I'm thinking about.
yeah. Well, and when I attended, global mental health presentations, which isn't my area, but yeah, they train like elders in the community to deliver interventions or, provide counseling services and find that they're very effective, and, they've had no formal education in mental health. So, yeah, I think, there's could be opportunities there.
Okay, I'm conscious of the time. I realize everyone has slotted this as for a particular period of time. I want to thank Will for a very well presented and thought-provoking, and I think something that has a lot of interest and potentials. I really wish you well in the effort to sort of further enhance these things. So be well, everybody. Thanks for attending. And we'll see you again soon.
Thanks, Will.
Thanks,
Will,
y'all.
take care.
Thank
Yeah.
you.
Good to
Bye-bye.
see y'all.
Bye.
Bye.
Good to see you, Will.